Patients pay out of pocket for services, whether it's plastic surgery, whether it's dermatology, whether it's other services. And now you're not only offering your service and the best service, you also have to offer the best customer experience. You also have to offer the best surgical facilities to them and how you cater to them. Do you offer them a room at the Fairmont or the Ritz after their private surgery? Do you have a nurse that comes and is available 24 hours a day to go check on them after the surgery in their hotel room? You're now starting to sculpt an experience for their surgery rather than just, I'm the best surgeon, I do the best work. You have to pass on and create an experience for them.
Welcome back to the Business of Influence. Today we're diving into the side most business owners never think about, how clinics actually work behind the scenes. My guest is Dr. Dave Verkh, founder of Vitalis Strategies. He started in medicine, added an executive MBA, and now he's basically the Alex Hormozi for healthcare, fixing broken clinic models, optimizing operations, and turning overwhelmed doctors into real business owners. If you've ever wondered how a medical practice makes money or loses it, you're about to find out. So let's get into it. Well, Dave, welcome to the Business of Influence.
Thank you for having me. It's a pleasure and I'm excited.
Me too. I want to start out with understanding your background and how you got to where you are. You started in medicine. I don't know if you planned to ever get into business when you first started out, or if there was a different path that you thought you were going to go on and then you noticed something in the market, a gap that made you want to jump into business. What was your thought process in the beginning? What were you going after, and how has that changed over time to get to where you are now?
I tell the story every time I meet a client, but you're absolutely right. I did start in medicine. I did my schooling and rotations and everything else in the US, primarily Phoenix. I was in Baltimore for a little bit, Chicago a little bit. I was always entrepreneurial as growing up. I always loved and had an interest in business management, how things are run. And then when I got to the US, things changed a little bit. It's a very privatized market. It's a very profits driven market. And I saw a bit of an opportunity that we don't really have in Canada, is understanding both the patient side and the business side and how to combine those into an efficient and optimized system. Did some rotations in very large hospital systems, and a lot of their execs, a lot of their top brass is what I call it, are always MBAs, always have these high business degrees, but they don't always understand the patients and how their decisions influence patient care and physicians who are in the front lines essentially. So I decided to do both. I decided to get my medical degree. I decided to then go do my executive MBA to really understand and combine the two, which kind of landed me to where I am now, which is essentially working with healthcare organizations, facilities, physicians, medical directors to work on their practice, look at the patients, how they're being seen, what the patient flow is, to the operations, and of course the finances, which is the lifeline of a clinic.
Right. So tell me a little bit about the business side of a clinic. And you said that in the US, you noticed that it was a lot more profit driven. Does that mean in Canada, people don't care as much about profits? And I imagine that could become a big problem for the longevity of a clinic.
Well, the funding models are completely different between Canada and the US. In the US, the funding model primarily is insurance based. If a person does have insurance, a patient does have insurance via work or they pay it themselves, a lot of the funds do come from and payments do come from Medicare, Medicaid, which is government funded. So you have to work on different areas, different streams of revenue, and understanding how and when you get paid for multiple systems. Canada is a bit different. Canada, I mean, the majority of it, in some aspects, all of it, in some sectors, it's all government funded. So a physician essentially sees a patient, and then based on what happened during that encounter, they bill the government certain fees, certain codes, and then they get reimbursed for that visit after X amount of days, months, and so on. So fundamentally, it's starting to grow in terms of competition between different specialties, and within the same specialty as well. Dermatology, plastic surgery is an example. Practices are trying to compete for the same patient essentially. So that's starting to grow more of a capitalist type of approach, which is very similar to the US model. However, historically, you open up a shop, you open up a clinic, a physician just came out of residency, and they hire an operations manager or a clinic manager, and the clinic manager runs their practice, and you learn as you go on. There's no business training, there's no understanding of cash flows, of how fast you're going to get your money from the government, how to pay your employees, how to do taxes
Hmm.
for a corporation, and budgets. And that's a whole other thing. They don't understand a lot of time, and it's not their fault. It's something that they've just never been taught, is preparing a budget with somebody for the next year to make sure you are within parameters of where you need to be. And of course, planning for the future, right? Inflation, deflation.
Yeah. When a medical practitioner goes from being the practitioner and starting a clinic on their own, let's say, they have to go through, I guess, a shift in their mindset, because now you're no longer making your money by billing codes and just getting a portion of that revenue. Now you're taking on a lot of risk that I guess you need to find the doctors that are going to serve the patients. And tell us a little bit about how a physician would make money versus how a clinic would make money.
That's a great question. So you're absolutely right. There has to be a shift in mindset for a medical director, for an owner. They go from being simply a physician to now being a business owner, to being an operator of the facility. So number one, I just like to talk to the medical directors out there and potential medical directors out there, is there needs to be that drive as well. Recommend all physicians open up clinics everywhere. There needs to be a special type of drive to be a business owner. It's not simple, but it is worth it. Now, how a clinic versus a medical director makes money, that's a great question. Um, Very similar to any business in terms of being a shareholder. So you're a shareholder of the practice, whether you own the full thing or you have partners in the clinic, and essentially the business needs to make money, and then you take out from the business whatever the business pays you via dividends, via salary. The interesting part about medicine is the business gets a percentage after all the doctors are paid. So you see a patient as a physician and you keep X amount of percentage. It's usually the majority percentage, so over 50%. That's automatically paid to the physician. Now, the rest of it goes to the business to run the overhead, to run the expenses and everything else that a business needs. So we're talking wages for nurses and staff, the manager costs, rent, utilities, your internet, your electronic medical record, plus a bunch of other medical equipment that's needed. So after all that is made, and paid for, hopefully you're left with something at the end, that you can draw dividends from, or draw some sort of profits from for the owner. A lot of the time, that's not the case. A lot of the time, a lot of specialties, that's not the case, for a myriad of reasons. Whether the government fees are way too low to even run a sustainable practice,
Mm.
um, or the facility simply just not optimized, not efficiently optimized. Maybe they have too high of labor for what they need. Maybe their technology costs, just costs in general, are extremely high. So when you shift from being just an associate to a medical director, you have so many other things to think about. An associate comes, sees patients, does their notes, bills the government, or in some cases, the clinic helps them bill, and essentially goes home, and of course takes their pay. It's a very different mindset and responsibilities.
So there's a lot of factors there I want to kind of hone in on. So the success of the clinic is partially tied to the, I guess, success of the physicians as well, because if the physicians are not seeing patients, and I imagine that in Canada that we always hear about how we don't have enough doctors. So getting patients shouldn't really be a challenge, although maybe it is. Do you see a difference between clinics' ability to attract patients? Because if they're not attracting patients, then they're not billing, they're not getting a cut of the fees, and then they have no way to pay for the overhead. And I guess if the clinic isn't bringing in patients, how are they going to attract doctors to come and work for them? Because the doctor also is taking on the risk of not having any profit if they're not seeing any patients, right? Unless I guess the clinic is guaranteeing them a certain amount of patients or a certain fixed fee, it's going to be difficult to attract the doctors to come and work for them. So would you say that certain clinics have challenges finding patients, or is it pretty easy for everybody given how we always hear about how there's not enough doctors to go around for these patients?
That's such an interesting topic. I actually just got off a call with a client not too long ago about this issue. Really, you're absolutely correct. In medicine, and I hate to frame it that way, but that's just how it is. Doctors equals revenue. There's no way of going around it, right? If a physician sees a patient, they bill for said patient, or they bill them privately for a private service. So if there's no doctors, there's no revenue. But to that extent, if there's no patients, there's no revenue. So attracting patients is absolutely necessary, which is why we've seen over the years, as I mean, I'm in Calgary. I know the Alberta market very well, but I also know the Toronto market very well. We've seen a large number of clinic openings, which drives the marketing dollars significantly higher. Over the years, the last 5 to 10 years, we've seen marketing costs just absolutely explode for clinics. And you're probably thinking, well, how do you market to patients that you bill the government for? Well, you don't. It's a lot of it is brand marketing. A lot of it is making sure that your clinic is at the top of any Google search when you search family doctor in Toronto, let's say. And it's the services that you offer within the clinic. It's the reviews that you get as a physician and a clinic. It's how you treat the patient. It's what else do you offer? It's how quickly do you address the patient's problems? So we've gone a long way, especially 30, 40 years ago, where the doctor is kind of like is that person that says, well, you have a cough, here's a syrup, here's some meds, go home and rest, to now being very much so customer service driven, very much so customer success, and the customer is the patient. And now you enter into the privatized world where patients pay out of pocket for services, whether it's plastic surgery, whether it's dermatology, whether it's other services, and now you're not only offering your service and the best service, you also have to offer the best customer experience to them. You also have to offer the best surgical facilities to them and how you cater to them. Do you offer them a room at the Fairmont or the Ritz after their private surgery? Do you have a nurse that comes and is available 24 hours a day to go check on them after the surgery in their hotel room? So you're now starting to sculpt an experience for their surgery rather than just I'm the best surgeon, I do the best work. You have to pass on and create an experience for them, similar to Disney. Right? Disney very much so creates an experience rather than the rides. The rides are great, but it's when you enter the park, you're in this world of Disney, and that's kind of what we're starting to see more and more happen in the Canadian market.
Yeah, let's talk a little bit about the macro level and how like inflation might be affecting the industry. I'm curious if this is changing the models for a lot of clinics to go more into the private direction. And I don't even really know what they're legally allowed to do in terms of private versus public healthcare. So I imagine that global inflation is causing higher overhead for clinics and like even starting a clinic, I imagine you need to get financing to do that because you don't have the cash that you need to set up all the equipment and start paying the rent. So I'm curious, if people are just working in public healthcare, they don't offer any private services, then their primary source of revenue is going to be, or their only source of revenue, I guess, is going to be from the government. And they use different billing codes to bill the government, right? Have those billing codes changed over time with inflation, or do you see that they're still pretty similar to what they were like 5 to 10 years ago? And if so, like what can clinics really do? Like the margins, if they're already thin, how are they going to pay for their overhead without going to the private route? And then what are some of those options? I'm throwing a lot of questions at you here, but
No, this is
they're
great. I
somewhat
love this.
related.
I love this. No, all of these are very, very related. I'm going to start by talking a little bit about the fees and the codes. I think that's a relevant starting point. Different bodies have different advocacy levels within each government. Some are nonprofit. I'll talk a little bit about Alberta, which is very similar to the Ontario market. Alberta has something called the Alberta Medical Association. They're a bit like an advocacy group for physicians for a lot of different areas, but a lot of it does come to fee codes or code fees, and then whatever you build, that's how much you get back. So over the years, we've seen very much stagnation on the codes in how much they pay. Some have changed. I don't want to say it's all stagnation. Some certainly have changed. The Alberta government just recently released a new fee code to pay family physicians for their administrative work. So there's a lot of admin work that comes with family offices, insurance paperwork, and just a bunch of other admin work that physicians have never been paid for. So, you go in, see a family doctor, they spend about 20 minutes with you. They get paid $40, but then there's another 20 minutes worth of paperwork to do at the end. So that's never been paid for. And they do a procedure. The procedure you can bill for a little more with different codes depending on what type of procedure that you do. So we've seen maybe a stagnation with a little bit of an increase, but certainly nowhere near where what we need and what physicians need to cover any inflation, or any percentage of yearly inflation, rather, not even a combined inflation over the years. So that's something that AMA I know is working on. The physician advocacy groups are working on. Some physicians, some sectors have very good returns and fees. Some have absolutely terrible ones. It's not all even. To kind of comment on your comment that we all need more physicians, absolutely. But relating to the fees, Alberta is now starting to pay for nurse practitioners to open up clinics and have a certain number of patients on a roster. And now they can bill the government as well. Before that wasn't the case. Before the clinics had to pay kind of like a salary or hourly rate to the nurse practitioners. From a private perspective, unless you're doing some private services, that model didn't always make sense because it's a very high salaried position. It's a professional position that a lot of the clinics can't justify based on you're trying to get more patients in, but you also have a very high salaried individual that a physician can just take over themselves. So that's one. Number two or number three, I don't know where I am in this list, but Scotiabank and a bunch of other banks have now really been forthcoming and helpful to physicians, to the medical and healthcare fields with financing, especially Scotiabank. And I'm in no way sponsored by Scotiabank. I just deal with them a lot. But what they have is, a few years ago, they bought out a sector of the Canadian Medical Association called MD. MD was the CMA's branch for healthcare funding. So any loans, advice, wealth management came from MD Financial. And Scotiabank bought out that portfolio and now have Scotiabank Healthcare with MD Financial. They're kind of like a joint venture under the Scotiabank portfolio. RBC also has RBC Healthcare, TD has as well. So all the banks are kind of getting there. But what it does is it gives the banks, healthcare is not really risky from a risk management perspective for a bank. So what they started doing is giving 100% financing for any clinic openings, new builds. They give 100% financing for acquisitions of clinics, for any share repurchasing. So let's say you have a partner and you want to buy out their shares, they give you 100% financing for that. Of course, you have to go into detail with pro formas and cash flows and all that fun stuff. One of the advisors that I always speak to said that the rate of default is well under 1%. So it's a very not risky business with a lot of upside for both parties. And of course, with that,
does it vary by specialty type by any chance?
No, it's healthcare. If you're a practicing physician, you get this ability to borrow, and they also give you a lot of rates that are much better than the average, like prime minus a quarter, for example, is typically what their loans are. I don't think I've seen prime minus anything in a very long time. But they also give you a working line of credit for any cash flow needs for your clinic. So they take care of you. The issue with that is you get into this situation where you have a physician who opens a practice and gets 100% financing, but they don't always know how to allocate their funds correctly. To the right areas. So they build out this beautiful practice, but now what? Now you got to start paying it back. You have to start getting some revenues in, and the loans are not small, right? They're multi-million-dollar loans generally. So you start getting into situations. So what I always recommend is about a 60-40 or 70-30, some sort of equity partnership into the business with somebody else. If you're a physician, don't have money right off the get-go, you can absolutely, and I think it's necessary to borrow, but there still needs to be some sort of investment from either a business individual or another physician, just some sort of involvement into the business. It creates a good risk balance.
Mm-hmm. So tell me a little bit about your company and like what are some of the common challenges that you're seeing these clinic owners face, and how does your company help them solve those challenges?
So Vitalis Strategies is a company. It's a healthcare consultancy that we have operating out of Calgary. Calgary is our headquarter, but we operate Canada wide. And what we really do, I call it the life cycle of a practice. So what that really means is all the way from the start to the finish of a practice, depending on where you are. If you're a new physician or a physician that wants to open up a practice, we walk you through the whole process. So from financing needs to builds. If you're looking to acquire a new practice, we want to make sure we evaluate it correctly, that you're not overpaying, that it's valued, at what it is, what you're getting from that. And then we move on to the heart of the operations, so operations and finances and financials. We look at your clinic operations. How do patients flow in and out of your practice? That's the biggest question. Do you have a call center? Do you have people answering the phones? Are they answering them correctly? All of that leads to patients coming through your door, which is equal to revenue at the end of the day. From my medical background, we also look at the medical affairs of it. So policies for medical health and safety, any questions with the college, so college regulations and compliance with the college, which leads, of course, to the financials. So we look at costs, we look at revenues that come in and out of the clinic. Physicians are excellent at knowing, and I love my fellow physicians when I say this, physicians are really great at knowing what's coming in. But a lot of the time they don't really understand or know what goes out in terms of costs and expenses, and a lot of time it's underestimated. So we really go through the whole picture of what's going in, what's going out, how it's going out. Do you really need that? And what are your benchmarks that you're setting, like in terms of, well, I could cut this, but it may affect this, or it may affect patient care or my ability to see more patients. Great, let's leave this, but optimize how you're using it. Instead of using 24 different systems, let's use 5 that you really capture everything within these systems, right? So that's kind of what we do. And of course, we do a lot of people management, not necessarily HR work, but understanding the type of people that you want your practice to have. So we do a lot of analysis on the physician. One of my partners does, he's been in people management his 30-year career, but he does a lot of disc analysis of the practitioners, understanding what type of manager they need to really run the practice successfully that complement the medical director, and what type of people are you looking for your front staff. A lot of it can differ, right? If you're running a family practice, that will really differ from if you're running a dermatology or a plastic surgery or ENT facility, right? Where there's a lot of private services. So the approach has to be different too. And that leads us to acquisitions at the end, evaluating your company if you're at that stage, if you want to retire, how to evaluate it correctly, what is the valuation, finding a buyer if you're looking for an exit, or if you're looking to pass it down. So we're working with accountants, we're working with lawyers to see what is the right way to pass on a practice where you're not necessarily affected by capital gains tax, and what is the right, is it a trust, what does that look like really?
Yeah.
And giving all the options to these practitioners. One last thing I want to mention about this: the acquisition market is really picking up in Canada, but it's nowhere near what the US has. A lot of practices still just give the keys to the landlord at the end of the day and close it. They don't sell it. They
Wow.
don't. It's huge, and that's something I'm trying to change. Is 30, 40-year career in medicine, you've built something successful. It may not be optimized to the end, but that's okay. There's still value there. One thing I will say is, if you are towards the end of your career in medicine or want to explore, the next 3 to 5 years, I would highly recommend reaching out to see what that practice is worth. If you have time where you still want to practice, let's build a plan to really optimize that practice for you so you can get the top dollar once you're ready to sell. Utilize exits. That's one thing I'm going to say.
Yeah,
Utilize
that's
them.
so crazy. I didn't know that. Are people just burnt out and they don't want to deal with all? That's so crazy. So they're just ready to leave all that money on the table and
They're ready to
wow.
leave all the money on the table. The sectors that are really getting picked up is derm, plastics, medical spas. That's something that's really getting acquired by a lot of different players out, out there. But your typical pediatric office, right? Your family practice, it may not be the most valuable, but let's build it to be valuable, more valuable than it is. A lot of people don't see that value. I do, and I think it could be really put out there in the market, and it is starting to pick up more and more with different players in the field. But if you're not out there exposing your practice to these players, it's never going to sell. It's never going to happen. And
A lot of what you were saying reminds me of some of the work that we do as well, because when we start working with a client, oftentimes they don't have a good set of financials. They've only been focused on compliance a lot of time. Like they just hire an accountant that they see once a year. They'll do the bookkeeping in one go and then file their taxes. They don't know if it's right. They just assume it's fine. They tell them what to pay. But we set them up on like a monthly system where they actually get financial reports and they actually start to track the financial health of the business. And then we also go in and we start looking at their expenses and seeing if there's any overlap between expenses. Like, are you really getting a good ROI on all of these things? Why is it that so many clinic owners aren't aware of what's going out? Are they just not getting a set of financials on a monthly basis? Like,
that's
yeah,
part of it. That's
okay.
that's that's certainly part of it. It's the lack of financials. So let's say you're a physician that has three, four other physicians working in your office, just one location. A lot of the time, it's exactly what you described. It's the once a year bookkeeping, file my taxes for me, please, and getting a picture at the end of the year. A lot of the time, they don't have monthly financials to really understand, what their costs are. So they're a little bit hidden from that. A lot of the time, they're just way too busy, to be completely honest. A lot of the time, which is the majority of the time, they're just too busy to even think about talking to an accountant, right? Talking to a lawyer about governance or do something that the practice needs. So a lot of it is very much so, well, it's Monday. I have, a full day of patients. I'm done at 5. When am I going to talk to my accountant, right? It's kind of like the 247th thing on their list to do,
Right.
which is, I'm working with a few great practices right now, and that's the case. They're just too busy every day with patients, with operations, with other things that they need to do, and they're fantastic operators. It's just got to a point where one person can't do it all, right?
Yeah.
And they're behind, or they're not behind, but they just don't want to do it themselves anymore. They want a clear picture. They want to see exactly month by month what they're seeing, and what they're doing, what they're spending, and how can we decrease those costs, right? And that's something that I think is so needed. It's so absolutely needed on a monthly basis. It's dollars well spent to an accountant, truly.
Yeah. Yeah, you need a clear picture to be able to improve things. So even when you come in, if they don't have that, what are you looking at to help them understand where their money's going?
That's exactly it. My first call is to their accountant. It's hey, can we work on these financials? And because I need them, you need them, the physician needs them. So let's collectively work on this, get this done, so that I can go and do my work and decrease those costs, understanding from an operational perspective what's needed, what's not needed. So my first call is usually to the accountant.
And how do the accountants respond? Are they equipped usually to provide that type of service, or do they now need to find a bookkeeper that's going to help them on a monthly basis and keep the accountant for the year-end stuff?
I'll say it depends. Some are bigger firms that can certainly handle that. Some are like, oh, yeah, let me get back to you in a day or two to see what kind of capacity we have.
Hmm.
So it really depends on the account and the firm. Yeah,
Yeah,
that's
it
certainly
depends.
it depends. It depends.
Yeah.
But I mean, you need a clear set of statements and all of that for the account to even be able to do that work.
Right. And so you go in, you talk to the accountant, you help them set up. Are you like, do you have a set of financials that you that are sort of uniform between all of the clinics that you work with? You expect the accountant to prepare them in a specific way so that you can measure KPIs in the same way every time? Or does it really vary depending on how the clinic owner wants to see the financials?
Yes and no. So if I'm going into a practice and then we're kind of going, my first call is to the accountant and we start working on that together. Then I ask for certain things, P&Ls and balance sheets. I really want more of a deeper dive into the liabilities, into the expenses, not just a one-liner saying like costs or expenses.
Mm-hmm.
I really prefer them to really dive deeper and actually list them. It's not common for them to do that because, well, it's a lot more work and a lot
Mm-hmm.
of time it's not needed. But I want to understand how much they spent over the last month or year, whatever that time frame is, on, let's say, technology. Okay? So it can even be branched by different sections or headers, which I'm
Mm-hmm.
totally okay with. But if you're doing, let's say, technology versus wages versus management costs, if they have like management fees that they pay like somewhere else, right? I
Mm-hmm.
really want to dive into those. 'Cause at the end of the day, all those are coming out of the account. So for me to say, well, let's cut 20%, which is equivalent to X amount of dollars, it may not be realistic. So I have to really understand what they're paying for specifically. And
Yeah.
even if I have a set of P&Ls, I always ask for the last 3 months of statements and credit card statements to go line by line.
Mm.
It's a lot of work, it's a lot of time, but it helps put a clear picture out to the medical director, to the owner, and say, look, over the last 3 months, you have spent X amount of dollars on this software that I don't know what the software is. Do you use this? Right? And that's kind of the approach I take. A lot of the time, I want to know what their liabilities are. Do they have term loans? Do they have some sort of working line of credit? What's the interest that they're paying on things? Things like that I could go in and potentially renegotiate and help them get better rates, better terms, better covenants on loans. So to answer your question, yes, I would like it a little bit different. A lot of time I don't get it, but that's okay.
Yeah. Are there common places where you see most clinics just burning through their cash and you go in, you're like, we need to look at this first because I see this all the time?
Yeah, one big fat one called technology.
Really? What kind of technology are people overspending on in this space?
Everything and anything that is found on Google. So a lot of these places, a lot of these companies have very, very sophisticated and trained sales teams.
Mm.
Very, very good sales teams, and they don't let you go. So answering services one is one I've seen that the cost just balloon like crazy, like it's just
Wow.
insane, thousands of dollars a month. And then goes to others like small little tech companies that do very small things or potentially do very small things that you don't actually need, but they promised the world to these medical directors, right? They promise that they can get them all these different things. They can manage their workflows much better. They can do upload sheets directly into the EMR, even though these tech companies physically cannot integrate with the electronic medical record. So, they promise all these things, but the problem goes back to my other point, and that's the medical directors and owners are too busy seeing patients, providing patient care, providing services to their patients to worry about all these tech companies. So it gets forgotten, and
Yeah.
and uh, and it's not their fault. I'm gonna keep repeating that part, but it's not their fault because they're trying to do the best by their patients. So they potentially sign up because of a good sales pitch, and they promise all these things to them, but they never opt out or they never actually, get rid of that software. A lot of the time they get drawn into these multi-year contracts as well.
Yeah.
So technology is a big one. The next one would be labor, would be wages. A lot of the time, there's no budgets, so it's hard to predict or forecast your labor based on your needs. So in that case, what I like to do is a lot of the time when you look at your reimbursement from the government, how much you actually collected, not how much you billed, but actually collected. I like to take that as a percentage of the operating cost of how much it actually takes you to operate the facility versus taking that of how much you build. Yeah, you're gonna get 90, 80, whatever that percentage is of how much you build versus how much you actually receive. What's more important is to see how much you received versus how much it costs you to run the practice.
Hmm.
And so that's something that I always like to put in place as a KPI is to see how much dollars are you bringing in from the ministry versus what it costs you to run the place, and then we look at everything else. But the bare minimum, as I call it. The bare minimum, keep your lights on, keep your staff paid, make sure wages go out on the right days, get your medical supplies that you need for patient care, um, and really understand what those numbers look like. Do you need to increase your revenue? Probably. Do you need to decrease your cost? Again, probably. Where are we starting at the end of the day?
Yeah. So with the tech, I guess like what I see a lot, and not in healthcare, but in any type of business, is they won't really explicitly state what the metric of success is for that particular cost. And
Yeah,
then they won't look back either to see if they hit any metric of success. And like with doctors, I guess they're so busy that they just don't have time to reflect back. But yeah, that's crazy to me that people will just go into expenses and have no idea what actual success looks like. What's the ROI that they're expecting on this expense? I see it all the
sure.
time.
I asked him a question right off the bat, like, how do you measure conversion here? Like, what is your
Mhm.
definition of is somebody calling? Is somebody like booking a surgery? Like, what are you doing? And it's usually, and the right answer to that is usually multiple conversions that you could track along the way and see where patients fell off, right? Are they not booking at the end? Well,
Mhm.
that's probably conversion number five, right? So you can see the gap, right? But to your point, you've hit the nail on the head. Is these companies they sell you a dream, they sell you this big picture that you can do anything, especially in health tech. Health tech has ballooned and is absolutely exploding, especially via accelerator funds and startups, which is incredible to see the tech that's coming out now. But it needs to serve a purpose for that provider. You can't just buy it all and expect it to all
Mhm.
work together well or just well in general.
So how do you help somebody start tracking conversions? I guess when you come into a clinic, they don't even have a system in place to track that effectively. Do you just help them with a spreadsheet and just tell them to manually enter it? Do you recommend a software of some sort? What do you recommend?
Some practices that come in and they usually have a digital agency that tracks. Some are very good and track conversions like to the T. It's so good to see. But some are not that sophisticated. They assume a lot of the time of what a conversion
Hmm.
is. Like I filled out your form on your website. Well, that equals a conversion. No, that equals somebody showing interest. So
Yes.
somebody reaching out is not dollars in my bank account. So we start with actually not even tracking. We start with what is your patient flow? How do you get your patients through your door? So we go
Hmm.
through that whole process. I usually take them to a boardroom and we draw it out on the board of, from point zero, what services are you offering to how do patients know you exist and your
Yeah.
practice exists? And do they know what services you provide? Maybe, maybe not. A lot of time it's like, oh yeah, a lot of them know via all these different methods. I'm like, that's fantastic. Let's go to the next section, which is from there, it's how do they contact you? How do they get to you? And
Hmm.
then the next one is, well, once they get to you, who answers that? Is it your receptionist team or your MOA team? Is it a specific person? And from there, I'm asking, well, who closes the deal? How does the closing of the deal look like, right? Do you take deposit right away? Do you take it within a week? So we go through all these different scenarios and find where the gaps are and where the holes are.
Hmm.
No process is ever perfect. I'm just going to put it out there. No process ever, even in the best of clinics, is perfect. But the gaps certainly can be smaller, can be shrunk down. You have your team who needs their accountabilities, their responsibilities, understand what their roles are when it comes to that. So we really look holistically at the picture of measuring each and every segment, which then leads to my final one, which is the actual closing of the deal, which leads to the conversion. That's the
Right.
final conversion, right? And then whether it's government or privately funded, you seeing the patient and performing that procedure or that service is the final conversion. It's what leads up to it. That's, I think, a lot and critical.
Yeah. So basically, there's a lot of steps along the way. If you're not tracking all of this stuff, you have no idea where you might be losing a customer, right? And you go
Exactly.
in, you actually help them understand the funnel and then figure out where they're losing that customer and where exactly they should be focusing their efforts to and what they should be improving.
Exactly.
That's
Exactly.
amazing.
Yeah.
How's speaking of technology, is AI changing a lot in the industry? Are you using AI at all in your own work, or do you recommend to clinics that they start implementing AI in some way? How is that changing things?
That's a very, very valid question. So to answer your second question first, I absolutely use AI in my day-to-day work. I think it's come a long way over such a short amount of time.
Oh yeah.
It's only been like what 3 years since like
Yeah.
ChatGPT has been released. But it's come such a long way. And if you, from what I learned, that I did a bit of research on how do I maximize and get the best results from my prompts? That's kind of my like that's my biggest question is I give it a prompt. I want it to give me what I'm looking for at the end of the day. So where I use AI heavily is analytics. If I have, let's say, an Excel doc or two Excel docs that I need full analytics on, and I give it the parameters of my analytic, like what do I really want to get out of it? And it recommends. So first I ask it to recommend me certain analytics, certain indexes or indicators that I may have not thought of.
Mm-hmm.
So it's kind of like I use it as a suggestion tool. Then I ask it to compare the documents or to really go dive deep into the Excel document, right? And I usually, with every Excel document, I already have some KPIs in there that I know I need, but I'm always looking for more. I'm always looking for something maybe a bit more specific. So I ask it to perform that and create the formulas to give me those KPIs and things that I may be missing. So I use it heavily for analytics, for analysis. On the financial side, I'm always looking for comparisons, comparables. You being in the financial industry yourself, we always do either multiple comparables or comparables to benchmarks out there. It's so good at doing research right now, especially that deep search feature. If
Mm-hmm.
you navigate it to a certain area and ask it a certain question, it will come back with sources that you have to double check, make sure to double check the
Yeah.
sources, but it will come back with comparables in the industry. For example, wage grids. If I'm looking to do, or my staff is looking to do some wage grids for a client, then we need benchmarks, we need ranges, and the research it does is absolutely incredible, and it's all cited. That's one thing I always do, is make sure to cite my work with where I got this information from, so it's not just pulling out of thin air. For clients, clinics, doctors, AI is huge right now, especially when it comes to scribe. So if a clinic, so I work with honestly two different types of clinics. One is a clinic that the doctor does the notes themselves a lot of the time. And the notes are done by typing, by either recording something. It takes a lot of time. The other side of clinics that I work with, where they have support the allied healthcare professionals, and those are your nurses. So your licensed practical nurses, or in Ontario they're called RPNs, registered nurses in some cases, and they support the physician by being a scribe and in operations and in procedures. But a
Mm-hmm.
lot of times they're the professional scribe. So a company that I know very well, actually, out of Calgary, called Mikata, they have an excellent scribe tool that integrates directly into the electronic medical record. And essentially you click a button, it turns it on, and with artificial intelligence, it creates a whole note for you, a whole what's called a
Mm-hmm.
SOAP note, which is the subjective, objective, and so on. It creates a whole structured note for you that you can then press another button, goes directly into your EMR. So you don't spend the time, like the additional time and the extra time to sit there and document everything,
Mm-hmm.
because it documents it for you. So, of course, consent is needed from the patient. So that's where I'm working with some clients to amend their informed consent for patients to make sure they're okay with it. But that leads us back to my previous comment of process. Just because you have a consent doesn't mean your front end team knows about it and your nurses are implementing it, right? So how do you know, like, if you, Daniel, came into the clinic, right, and you're like, I don't want this used, you say, so you opt out. How does it get to your doctor that your doctor then knows, do not turn this scribe on, right? So
Yeah.
that's the process side. You always need a process side in the clinic, right? So,
Yeah. Do you
like I
find
said,
that those
yeah,
are lacking a lot when you're working with your,
absolutely,
yeah?
absolutely. The front end a lot of the time doesn't talk to the back end, which is the medical end usually, and there needs to be a connection, right? One is administrative and the other one is a medical or surgical end. And they do two completely different things. Both are so important in a clinic, but it's a matter of communication between the two and processes between the two
Yeah.
to make sure that everything is cohesive. Otherwise, it falls apart really quickly.
Yeah. So there's a lot that you're coming in. How long do you work typically with a client?
Depends on the project. We moved away a little bit. We're still doing it, but we moved away from the project based, I would say, because we found that when we come in, there is a bit of like, I want this done. I want you to implement this. I'm like, great, no problem. We can do that. But then we find all these other things that connect to that.
Mm-hmm.
So what we come, unless it's something very specific now, like let's say they're looking at an acquisition and they need some performance done, right? Like no problem, this is what it is. But and they don't need any other help. No problem, we do that. But what we've kind of started shifting towards is more of a holistic model. Is more of coming in essentially as your C-suite. It can be a small practice, right? And the C-suite, they can't afford a C-suite at the end of the day, because well the margins are so small. So they hire myself or a firm to come in essentially as their C-suite, and we start prioritizing. We start looking at like, okay, where are your biggest gaps? Where are your biggest and most urgent issues that you need to take care of? And we start chipping away at different things. So the length of the of the arrangement is usually pretty long. I would say definitely a year, sometimes longer. Sometimes it expands beyond that into different projects.
Mm-hmm.
Sometimes it's very quick. Sometimes like, well, I need you to do this. No problem, we'll do it. But a lot of the time it's coming in and doing an audit first. And that takes a little bit
Yeah.
of time. You have to know what you're working with before you start, working. And my biggest thing is understand why the fence was put up in the first place before you start chopping the fence down.
Right.
Why was the process integrated first? And it may be working very well, but in your mindset, you haven't done that type of thing. So you're like, well, let's tear it down. Like, no, let's pump the brakes, see why this was put up in the first place. Change management is huge. That takes time.
Mm-hmm.
Making sure that not only the medical director is on board, other associate physicians are on board with what you're doing, your staff, or their staff rather. So the nurses, the front end team, they're the ones that are actually going to be using what you're putting down. So training, explaining, change management, that's a big one. That takes time. So I would say certainly months.
Yeah.
And then, we're a fairly new consultancy. So I'm curious how long my longest one will be, if that makes sense.
Yeah.
Shifted towards more of a holistic C-suite, kind of like a fractional C-suite that
Yeah.
would come. That's kind of what it shifted towards, and the results have been much better.
And so do you have a lot of competition? Is there a lot of other companies doing the same thing you do? And do they usually come with a medical background, or is that something that sets you apart from some of your competition?
Certainly sets us apart from competition. I'll
Yeah.
say the biggest competition that I'm just talking about Alberta's in general, but there's a few healthcare consultancy firms, but they don't do what we do. The reason I say that is they're not focused on execution and boots on the ground. What
Okay.
they're focused on more is strategy, PR, communications. If a clinic or a facility gets themselves into hot water with whatever, then they kind of take over or assist with that. They're not a boots on the ground. Let me help you actually get this done. Let me
Right.
help you fix this or scale you or grow you. And this is where we differ, is that execution piece. I'm a big believer in actually executing. And we of course have the big firms out there like the Deloitte, KPMGs, the PwCs. They have the healthcare teams as well, which are so very good. They're more focused on the publicly funded systems. So here it's Alberta Health Services. Toronto, of course, it's the Trillium Health. It's the Toronto General Hospitals, Mackenzie's. They're focused more on the strategic end of that, or of course on the audits, on the risk mitigation, the taxes, the financials, not necessarily the clinic operations. A lot of the
Mm-hmm.
time, they deliver a very extensive strategy report to you, like a big binder. But a lot of the time, the clinic, especially if it's a smaller clinic, they have no idea what to do with that report.
Yeah.
It
And
looks
they don't have the
great,
time to do anything
and
anyway.
they don't have time, right? And nor the expertise, and no one expects them to actually have those expertise to to start, putting change management in place or integrating this and that and cutting this. They don't have the ability, whether it's scale, whether it's time, whether it's whatever else reason. So you pay a lot of money for something that you may not be able to execute at the end of the day.
Yeah.
So that's really how we differ. We're the boots on the ground. We work with you directly. I work with you directly, or my team works with you directly. We involve teams such as accountants, lawyers that we have incredible partnerships with preferred rates. So things get a little cheaper. And I always say to my clients is, unless it's project based, my fees and my firm's fees should never be a line item in your P&L or anywhere else. It should never be a line item. The reason I say that is we're going to do things, whether grow you, whether cut costs, that you're never going to feel my fees.
Mm-hmm.
And they, so far, I have absolutely delivered on that. And I track that because that's a reputation thing, right? That's a big thing. Whatever I charge, whatever it costs, I want to make sure that I deliver more than, like, it makes no sense
Yeah.
for me to be there if they're just paying me my fee. I need to deliver something. I need to give them value.
Yeah.
So that's something I track quite a bit.
I love that. We do something similar to when we implement our profit first forecasting. We also typically find more profit than what we cost our clients, and
Yeah,
it becomes a no-brainer. Why wouldn't somebody hire you? You're going to give them basically a guaranteed
absolutely.
ROI. Amazing.
Absolutely. That's so
So
important.
if somebody wants to work with you, what would be the best way to connect with you, find you online?
So we have a website, vitalisstrategies.com. It's quite thorough. We made it quite thorough on purpose to really give an understanding of what we do and the different stages of a clinic. So all of that is there. There is an email, there's a phone number there, there's a connect with us form as well. You can always get in touch with me directly on LinkedIn or emailing me, dave@vitalisstrategies.com. Very, very simple. If you want to go out for coffee, virtually or non-virtually, I'm always open to that. I love a conversation first. I'm always a conversation first type of person to see. I want to hear your thoughts, your vision, and I want to make sure that that we're a fit, that we can do what you're looking to do. But it has to be always mutually beneficial to both parties. So I want to make sure that you're going to be gaining a lot out of our whole relationship and our services to you.
Amazing. Well,
Yeah.
Dave, thank you so much. This has been wonderful. I'm excited to see where you take this company.
Likewise, I thank you so much for having me. This has been great. Lots of synergies between operations, healthcare, and of course what Measure Growth does. So I love that. Thank you for having me, and looking forward to further chats.
Sweet.